Good evening, everyone. Welcome to the Orem Meridian. And the next episode, I'm your host, your guide to dental excellence, Robert Hawkins. And today, my guest, he's talking about something scary. He might be the Superman of endodontics. At least he looks a little bit like Superman. So he's going to guide you through it so you're fearless when it comes to what is probably the most feared phrase for patients anyways, and that's the root canal. Dr. Bill Nudera. Dr. Nudera, welcome. Thanks for joining
Hi.
us.
Thanks, Robert. I really appreciate being here and being able to share my story with your audience and hopefully educate people on some endodontics.
Fantastic. Tell me a little bit about you, and for the audience, maybe there's some people who aren't familiar with you and your work. Give us the elevator pitch of how you got to where you are and why you are the man of the hour when it comes to endo.
Well, I'll give you the abridged version. I graduated dental school in '99, so I've been a dentist now for about 26 years. And when I graduated dental school, I hated endodontics. I didn't know how to do it. I didn't understand it. It was kind of a scary place for me at the university. I graduated only maybe doing a handful of root canals, and I barely did those well. Spent some time in the military in the United States Air Force, and at that time, I was able to connect with a colonel who was a board certified endodontist who really saw that I was struggling a little bit, but saw that there was some interest there. So for a couple of years, when I was stationed at a base, he helped me understand endo at a greater level. And I said, you know what, this is something I really want to do. I really want to focus on. And I separated from the military, decided to apply to some endodontic schools, got into endodontic program, graduated in '05, opened a practice in '06. And that started my journey really into what I'm doing right now, which is education. I am a big into endodontic education, basically because of the way I felt when I was in school. You know, there's a whole lot of stuff that students have to learn in dental school, and this broad array of clinical curriculum dental schools have to kind of teach, and they don't have time to teach everything. And I get that. I get that. So I found this little niche outside of dental school to offer courses and offer training to those dentists who may not feel they got enough in dental school, because I know I didn't. And I know the curriculum in dental school has changed significantly since I graduated. And some dentists are graduating dental school, or students are graduating dental school without having done any root canal treatment. So my story went from a general dentist graduate who hated endo to a general dentist who learned endo to a general dentist who really liked endo to apply to endo to get into endo now to teach it. And that's where I'm at, and that's my passion. I've devoted my life's work to helping the next generation and anybody who's willing to learn endodontics, this craft.
Well, all of us non-clinical patients, thank you for spreading the good word at the eventuality, maybe not, hopefully not, when we may need a root canal and everything else endo. So that's a great segue into kind of the first thing I wanted to pick your brain about was whether you're a student or you're a general practitioner who, like you, wasn't really interested in endo, but is starting to dabble in and starting to find that niche like you. What are some of the most common mistakes that are taking clinicians down perhaps the wrong treatment path before, the endo really begins?
So endodontics is highly diagnostic, right? I mean, I mean, apart from the obvious tooth that it's broken down, or there's maybe a nerve exposure, or the patient comes in swollen, the obvious signs and symptoms, there's a significant population or a patient pool that we have to kind of get through that maybe have ambiguous symptoms or maybe that aren't so obvious here. And I think one of the biggest learning curves that I'm helping people get through is algorithmic decision making. I wrote a book about diagnosis, prognosis, and case selection, and I help dentists understand not only what's causing the problem, but if we choose to render treatment on this tooth, what are the odds that it's going to work? You know, we're in healthcare. There's no 100% when it comes to biology or healthcare, but we could prognosticate somewhat and try to treat the teeth that we have that we see have a more favorable outcome. If we look at the literature for endodontics in the success and failure studies, there are famous reports out there that suggest that endodontists can have a greater than 90% success rate, somewhere up of 95%. And that becomes the most most quoted percentage when dentists talk to their patients about root canal treatment. Oh, you should do a root canal. It's going to be 95% successful. Well, that's great in an institutionalized study with a healthy patient with a healthy tooth, right? But the majority of people that need root canals, they have damaged teeth. They're not in ideal circumstances. They may be a more of an elderly population too. Some older people are health concerns. So the statistic of 95% is overinflated, but yet that's out there in the literature. So that gets quoted. So then the younger dentist graduates dental school, kind of regurgitating that statistic, but later find out that they may not have that success rate. Well, lo and behold, that's not actually accurate. So understanding which teeth may fall into that category of the 95% versus those that may be less or even maybe 50-50 are really important because it's not only important to understand the prognostic value of what we're trying to help the patient understand, it also helps gauge risk, right? And if the communication piece has to be there. So if you come to see me, Robert, and you have a tooth that's broken down and there's an opportunity to try to save that tooth, we're going to go over everything about, what your options are. You can do, by the time somebody comes to my clinic, there's three things on the menu. You can do nothing, you could try to save your tooth with a root canal, or you can get your tooth pulled. Those are the three choices that we have to, go through with people. Now, when patients are in pain, they're swollen, they're not going to do nothing. They're going to want to do something. So now it comes down to this binary decision. Do I want to save the tooth or would I rather have the tooth pulled? So part of my communication piece when I go teach is, well, I'm going to present you the extraction first. I'm going to tell you, hey, listen, if you want to guarantee that this tooth will never ever bother you again, the only thing that's going to be as close to a guarantee in healthcare is to have your tooth pulled and remove your tooth. Not that I'm promoting that, not I'm suggesting it's a good idea, but that's an option because it comes with the highest success rate. Unfortunately, a tooth extraction is the most successful dental procedure we do. However, Robert, if you want to take a little bit of more of a risk, but a calculated risk, we should try to save the tooth. And in your case, maybe the success rate's 90%, maybe it's 50%. But now you get to look at that weighted on that 100% option and decide on whether or not you want to make that call to save your tooth. Because the reality is, they don't need me to do a root canal for them. They don't need anybody to do a root canal for them. They just need to make a choice on how they want to manage that case. And if they want to choose, because it's an elective procedure, if they choose to want to save their tooth, I'm happy to help them. And I will work very hard to get them to that elevated success rate, but there's always going to be some level of risk. So the communication piece is important to understand, not just understanding the prognosis, but helping the patient understand with an anchor of what that prognosis really means.
I really like the way you presented that. Specifically, you used a couple of tricks that, in the way you've actually spoken to me as your patient, is really important, I think, for the people watching and listening this as well too. Number one, there's part of the Cialdini method where you've loaded sort of the most invasive, biggest procedure first, and then you followed up with the root canal, which most people find to be even a little more scarier. The other thing that you did when you were just presenting to me, which I really like, is you actually said my name personally, I think three times in that presentation. It provides so much more of a personal connection for what can be for patients a much scarier conversation. So I think it addresses them a little more, puts them at ease. A lot of high-end hotels have the same standard as well too if they're dealing with a challenge. So for those people watching and listening at home, those are some tips and tricks that Dr. Nudera just did very naturally, and that's why he's been so successful. Uh, that's fantastic. So in that decision tree, and sorry, can you just say the name of your book again? Algorithmic diagnostic. What was
So
that again?
the book is called New Endo Rethinking Endodontics, and it's a book on case selection, prognosis, and diagnosis, prognosis, and case selection. That's what it's all about. And basically, it's not your typical textbook. Yeah, there's some paragraphs in there and introductions and things like that, but basically they're flow charts. It's an algorithmic flow chart, and it's like a choose your own adventure. So it's going to take you through the entire process from the time you shake that patient's hand until you make that diagnosis and understand what those options are. And I have an app that I built that picks up where the book left off, which then teaches the clinical technique, all in the same sort of conceptual flow of binary decision making. Because when it comes down to it, we're making decisions every day. And the decisions we make are either this or that. And if this, then that. And then if this, then that. And endodontics and decision making isn't linear. Language is linear, books are linear, but the process is not linear. So the book, although it goes through the process from start to finish, it's going to have closed-end loops, open-ended loops, which is going to take you back from maybe chapter 4 all the way back to chapter 2, or one system back to another, and it's going to help you work through the troubleshooting mechanisms until you finally get to the answer you're looking for. So it's a very unique way of approaching endodontic education.
I really like that. So, can you, in a nutshell, just to give us the insight into your process in the book, which we'll put the link to, by the way, in the description on the video when we post it, and when we post it up to your podcast as well too, would be um, what are your factors in determining if you need a treatment or another retreatment or surgery or extracting? Which factors matter the most in all of that? Can you summarize
Sure.
that for us?
And it's simple. It comes down to really three variables. Number one, the quality of the bone. All right, we're taking imaging, we're taking three-dimensional imaging. The basic lens that we evaluate prognosis through is the amount of supporting periodontium, specifically how much damage is there in the bone and where is that damage located. And there are three different systems that we use to understand prognosis through the lens of the bone itself. One of them is no bone loss. The other one is crestal bone loss, when the actual lesion starts affecting the alveolar crest. And the other one is bone loss without crestal involvement. So those are the three main pillars that the rest of the diagnostic information is based on. So once you understand the quality of the bone, the next thing you have to understand is the condition, structural condition of the tooth. Because I can do a root canal on a broken down tooth with no lesion and it's going to work, but there's nothing to function on, right? So biologically, we're looking at the bone. Structurally, we're looking at the tooth. And now the third variable that rolls into prognosis is the patient. Right? What are they going to do with that tooth when they leave my office? Are they clinchers? Are they grinders? Are they taking selective serotonin reuptake inhibitors, which one of the side effects is nocturnal bruxism? Are they abusing their teeth? So that's a variable. Those are variables we just can't do anything about. Is that patient aspect of it? So and again, that plays into what we talked about earlier. When somebody comes in and their teeth are flat because they're wearing them away, and there's big fracture lines in the tooth, a lot of bone loss. Does that tooth have a 95% prognosis success rate if I start it? Absolutely not. That's going to be a coin flip. But if the patient wants to flip the coin, I'm happy to flip it with them because I want it to work as much as they do.
That's so good. And so you've got this patient who's got all these variables and you've got some experience. So tell me what separates clinicians who are, you know, they find and manage these complex problems and address them beforehand versus those who are still struggling. What's the tipping point? Where do you find when you're talking to new grads, to new general practitioners getting into this, what's the tipping point from them where they can achieve that 95% success rate?
Well, first of all, 95% success. I'm going to frame this a little differently, Robert, because 95% success rate is possible when all the conditions are correct. But the tipping point to help people understand how to quantitatively evaluate prognosis comes down to interpretation of imaging. And I'm another big advocate of three-dimensional scanning for preoperative endodontic diagnosis and all 100% of endodontic treatment. We got our first cone beam scanner back in 2000, late 2011 or early 2012 when it was kind of this, or we're early users or early adopters, whatever you want to call it. But it was like the wild west of imaging because nobody was teaching us how to do it. Nobody knew how to do it. And the cool thing about that, Robert, is when you get involved with a new technology that's emerging and there are really no rules on how to use it per se, you get to make the rules and you get to shape how everybody else then in the future begins to use it. And I remember the AAE, which is the American Association of Endodontists, my governing body that supports everything that I do endodontically, came out with a position paper shortly after we got our scanner that says you should not be taking cone beams on every single patient because of something called a LARA, as low as reasonably allowable, meaning that if you're taking cone beam scans on every patient, Dr. Nudera, you're overexposing them and bad, shame on you, sort of thing. And then when I'm reading the position statement, one of the variables in there says cone beam CTs should be considered for any tooth with complex anatomy. And here I am thinking, well, there's my loophole. What tooth doesn't have complex anatomy? So now I get to take a cone beam on everybody. And then, several years later, they came out with another position paper to augment their first one, and given looser criteria. Now, fast forward to 2026, we've all got cone beams now. But the struggle that I'm still dealing with is the AAE and most recommendations and textbooks suggest that the two-dimensional imaging is still the standard of care. I'm hoping that that's going to change within my lifetime because the imaging is getting better, the resolution is getting better, the algorithms to process these images are getting better, and why wouldn't we want to see more? So the exposure of these CT scans is very minimal when we talk about dosing compared to medical CT scans and the information that we can gather. So what is the biggest value that I can teach to young people to kind of circle back around to your question is learn how to read cone beam scans from an endodontic perspective. And there's a lot of information out in 2026 can help you get there. We have got information on my website. We've got courses we do on that too, but it's very helpful because once you can look at that bone and that baseline variable that's going to really predict that prognosis, then you'll be ahead of the game. And that's the biggest thing I try to get across to my young students.
There's two things really that I draw from what you just said, and one is CBCT is absolutely the standard. We've got our imaging center here in Calgary, and we use CBCT, we use a Plan Mecha G7, and we chose that one very specifically because it's my understanding, and somebody can correct me if I'm wrong in the comments. Uh, there's no AI additive fill. It's 100% field of capture. And for us, when we're doing surgical planning, I'm assuming for you as well too, I don't want millimeters or micrometers of fill, of AI fill. I want to know exactly where those nerves are. So if I'm planning for a drill, it's completely accurate. Um, Lost my train of thought. So we'll move on. If it comes back to me, we'll do that. Tell me about, if you could completely rethink how dentists are approaching endodontics, what mindset or systems or principles would you want them to adopt immediately?
Well, I think everything comes back to helping patients understand its communication piece. The biggest issues that we have is after the fact, something happens, either it could be a procedural error or maybe something just didn't work. Maybe you did the most beautiful root canal or procedure in the entire world, and it's just you want to make a poster of it hanging on your wall, but yet something didn't work. And then what happens is the patient says, well, whose fault is that? Something failed, something didn't work, and all of a sudden they want somebody to blame, right? And I've made those mistakes as a younger dentist, thinking that well, you're going to save the world, you're going to save every single tooth. If in my hands I can make this work, and we'll look at images and see this really unfavorable aesthetic looking root canal treatment that looks beautiful and is healed well and it's been in the mouth for 30 years next to a beautiful sleek looking root canal with a lesion that just isn't healing. So the textbooks teach us we think the textbooks teach us what we understand about the success and failure, but they really don't. So I think the biggest thing too is all these things that we want to try to encourage the younger dentist to understand should be occurring during the consultation. Like when I spend a lot of time talking with my patients to help them understand risks and what is the ultimate risk of a root canal. Now, a lot of people in the audience, when I give these lectures, say, "Oh, it's a perforation. Oh, it's a separated instrument. Oh, it's this, that, and the other." No, the risk of root canal treatment is tooth loss, right? That's the risk. If you're not willing, it's the risk loss of time, loss of money, loss of your tooth. Those are the three risks that people are taking when they're doing root canal treatment. And that needs to be understood before the treatment starts. Because I don't care how good your root canal looks, number one, if you treated the wrong tooth or if it didn't work, right? And you've got to start preparing that patient for that possibility that, hey, listen, and part of my consultation rolls around not all root canals work the way we want them to, meaning sometimes symptoms are difficult to fully resolve in some circumstances, and not all root canal treated teeth last forever. Everything has an expiration date. So there was a motto in the AAE several years ago, at least I can't remember exactly how long. They had a tagline that says "Tooth for a lifetime." Hey, that would be great. But they took that down pretty quickly because that's just not feasible in many people's worlds, right? So now my philosophy is tooth for as long as we can keep it in your mouth. Be that a year, be that 10 years. Now, I'm going to go off on a little tangent, Robert, because this kind of reminded me of something about success rates. Because our definition of success is very different than a patient's definition of success. When we talk about success, we're expecting the success for me is if I do that root canal, I want that root canal to last 1 day longer than you. And that's a success for me because the root canal outlived you. And that's what I would love to have success. But that's not the reality. And I had a patient one time come to see me, and we did a root canal for him. It didn't work, so we did a surgery for him. It didn't work, but this was over like a 3 to 4 year period of time. It wasn't like we did one and failed immediately. It was like he came back, symptoms were gone, we resolved them. Then he came back for a second treatment, we resolved them, but ultimately the tooth had to be removed. That same patient returned to my practice with another different tooth that also was going to require some treatment. And I said to him, listen, I go, I understand if you don't want to do this because of what happened to the last treatment and it really didn't work and you ended up with an implant. And he looks at me and says, what do you mean it didn't work? You got me out of pain twice, and I got to keep my tooth for 4 years longer than what I imagined I would keep it. So, from his perspective, even though we had to go through a couple of procedures in order to kind of prolong the life of that tooth, he looked at that as a success. But from my perspective, what dental school taught me was that was a failure. But really, I had to reframe how I thought about success and failure based on that one patient. So now when I go in, if a patient is not ready mentally, because there's a mental game, the mind is a powerful thing, and I'm sure you understand that. And some people just are not ready to lose a body part, lose a tooth, and they're willing to hang on to that for another year, another 2 years, another 3 years until they can wrap their head around the fact that maybe they should get an implant. And maybe it's worth that investment of time and money to try to actually at least know that they've done everything they could to preserve that tooth before they just decide to have it removed. So, Robert, I forgot what you even asked me. I just went off on a tangent. I hope.
That's okay. That's good. It's perfect. I can empathize in the fact that, I'm 42. I had my first cavity. I've got pretty good dental, hygiene and dental genes. I had my first cavity in January this year, and I was like, oh man, I broke the streak, right? So I can only imagine how I'm going to react when I need my first root canal or my first, extraction or something like that. So, uh,
Well, I hope you don't reach that point, Robert. And with
me too.
modern dentistry and the availability of healthcare now, you possibly may never have to face that, right? Now,
Well,
me, I'm in a little different position. I've got a lot. I mean, I didn't take really good care of my teeth as a kid. So I can really empathize with a lot of my patients. I've got a crown, I've got several fillings. I haven't had a root canal yet, but I'm pretty sure that's in the cards for me. Maybe not for you, though.
maybe not. It would be interesting to see that. You should do a podcast on your first root canal and see if you can do it on yourself. It's just,
Well,
I
it's
mean,
funny you say that because I got a crown on my tooth number 30. And this was several years ago, and I had to have it redone. So I've had multiple treatments on this single tooth, and that's one thing that the pulp hates is first of all, it hates the drill because anytime you touch a drill to a tooth, it's going to create friction. That friction creates heat. That heat creates damage, and that burning is the trauma that the pulp hates. And that's the reason why we get post-operative sensitivity, all that stuff. But there's that fine line of damage that the pulp cannot recover from. So the more times that tooth is worked on throughout the lifetime of the tooth, and the deeper that tooth is worked on in close proximity to the pulp, are the variables that will cause a nerve to die sooner than what it was designed to do. So I had this tooth restored with a crown, and the crown came off, and I had it etched. I had it rebonded. There was nothing wrong with it, and put it back on, and it was hurting. It hurt, and I'm like, oh no, here it goes. I'm gonna need a root canal. And I know somebody could do it for me, which is fine. I've got a lot of good associates and partners and stuff that I can work with. But I'm like, you know what? I'm gonna sit in there and let this thing ride. I'm gonna try to experience maybe a little bit more my patients go through so I can understand their position a little more. And this started about 18 months ago. And I was making a diary, noting every little thing that happened when I bit on something, what made it hurt, what made it not hurt, when it felt bad, when it didn't feel bad, was it waking me up at night, all these things. And I was expecting for sure, Robert, that I was going to need a root canal. But now here it is, 18 months later, it's still testing vital and it's settled down 100% completely. So my recommendation to some people now, based on my own experience, is hey, maybe we can let this ride a little bit longer until you reach your tipping point. And once you reach your tipping point, I'm happy to get involved. Now, some people's tipping point is a day, other people's is a year, right? So there's one of my practices here in Chicago that I work up on the North Shore, and it's a very, very different type of community where it's a community where every little it's like a princess and a pea thing. Any little thing they need fixed immediately. So the challenge for me up there is to kind of talk them off the ledge a little bit. I'm like, yeah, you're supposed to feel cold when cold hits your teeth, but it's not lingering and it just started yesterday. So I don't think we need to do root canal yet. Let's give it a little bit of time. So that's been an interesting conversation for me to have with some of my patients as well. So perspective and everybody's tipping point is going to be different. I was fully expecting I was going to wait for this to necrose and I was going to experience the death of the nerve. It never happened. I'm happy about it, but it never happened
Why do you think that is? Why do you think you never experienced
because
going
I
past your tipping point?
Because well, I almost did. I almost called up my partner at the time and said, "You're going to need a root canal for me." But I said, "I'm going to wait it out because I know exactly what's going on. I think knowledge is power. If I understand what's happening, then that gives me more information to make my decisions with. Now, I'm not going to be stupid, right? If I'm agony and pain, I'm going to go do it. I never reached a point where I'm like, it's affecting my daily life or quality of life. It was affecting me, but I was still able to work. I was still able to eat. I'd have to shift my food to the other side for a little bit. I had to protect it from temperature, but I was able to do that comfortably, tongue in cheek wise. Now, the patient that is their quality of life is being impacted by the pain in their mouth, the functionality. They can't eat, they can't sleep. There's a different story to that, Robert. So I'm talking to you about what I consider to be the fine line between a reversible pulpitis and an irreversible pulpitis, and I was walking that line really, really close, and it turned in my favor. Gratefully, I'm grateful for that, but I was fully prepared for it to go the opposite direction.
Were there any kind of specific sides of either side of the line where you would talk to the patients who are Princess and the Pea versus in the other community, your other practice, where you would say, "Hey, don't grin and bear it. This is the point where you need to get it done," or was how did you frame that with your
Well,
patients, or was it
I frame everybody the same way. Here's what's going on. Here are the options. Is this affecting, how much is this affecting you, right? Are you ready to do it now? Are you ready to make the choice yourself? Or do you want the tooth to make the choice for you? So again, everybody's tipping point is different. And there's not one simple answer to that, but the consultations are all the same. Here's what I think is happening. Here are your options. Here's what I would do if I was in your position. Now, infections are different stories, right? If there's a lesion, if there's swelling, those aren't going to get any better. We know that. Radiographically, though, what we're talking about here, Robert, is the fine line between reversible and irreversible, and that is an extremely fine line. Now, I can make somebody's tooth hurt depending on how long I want to hold that cold on there, right? And so there's asymmetric information going on here. And so it's not just that you're trying to make somebody's hurt by putting cold on it. It's what their reaction is going to be after you put the cold on it, right? So if I'm testing my control tooth and they scream bloody murder when I touch cold to their control tooth, and that's a normal reaction. Well, how are they going to feel when I touch cold to the one that's really bothering them, right? Well, that's a person who's reached their tipping point, right? And that's also a person who's going to be very difficult for me to get them through the treatment, right? So there's a lot of things that we learn about the patient we're treating just based on the conversations I'm having and how they're responding to what we call considered normal testing.
over the years, as we're talking about patients and communicating with them? has your initial patient consultation checklist, we're talking with Dr. Manasi, she swears by the checklist, right? Has your checklist, your consultation conversation changed over the years from when you were a GP to really when you became master of endo?
Well, I can tell you now, first of all, they've changed twice. So let's go back to when I was a GP. My consultations were terrible because I didn't really have the experience. I didn't have the domain knowledge. I didn't have the judgment. When you're young, you don't, it's hard to teach judgment. You can teach domain knowledge, you can teach technique, but judgment is learned over time. And again, that's where my niches come in with this algorithmic teaching because my algorithmic teaching teaches judgment. It's baked into these algorithms, right? And so that's what I had to learn. But as a general dentist doing endo, no, I was quoting people 95% success rates because that's what we were taught. Then when I became an endodontist and studied for my boards, I started looking at this differently and thinking about this differently. So my consultations pre being an endodontist were almost zilch. I'm like, okay, let's do the root canal. That was it. And people are like, okay. And they just opened, right? And there are a lot of people out there that still approach it that way. And right or wrong, that's just not my approach. When I became an endodontist and learned all the bad things that could happen and all the complications that could happen, my consultations were 45 minutes. And then I was scaring people out of the treatment. I'm like, well, I can't do that either, right? So I went from one extreme
Yeah.
all the way to the other extreme, and now I'm here in the middle. My consultations now last maybe between 5 and 10 minutes, and they're all scripted. They're all scripted, scripts that I've worked on. Like you had mentioned earlier when I talked to you and gave you that virtual consult, I mentioned your name and I framed it a certain way. That is all 100% intentional, 100% intentional. And that's how I frame everything. So I practiced in the mirror. There's certain things that I need to hit in every single consultation. What's happening, why it's happening, what are the options, what are the risks? And those are the check boxes that I will hit. I've recorded several patient interactions that's available on my website, and you'll hear me, and I'll do the so what I'll do is we'll record the interaction with the patient, and then I'll sit down there and I'll watch my recording. And I'll break it down like a sports broadcaster and say, look, here's what I did this, and here's why I did this, right? So I break down those consultations, those conversations, because the communication piece is everything. You can be the worst dentist ever, but if you can communicate well, people love you. They love you. And I'm not saying that that's a good thing. I'm just saying that the communication is so powerful that it trumps sometimes the actual technique itself.
One of the things when I had a brain freeze earlier there was what technology are you using in your practice? So it applies to this next one as well too. We've got so much AI out in the world. I call it assisted intelligence, and I think the industry consensus is that the AI is never going to replace the final judgment of the clinician. It can certainly make their decisions a lot easier. Tell me, what technology, either AI or otherwise, other physical equipment, are you using at every step of the way?
So the AI, I've got very little AI in my practice at this point. The only AI that we're really embracing is pretty much the phone assistant, the one that's going to answer the phones after
Yeah,
hours and do my scheduling when I'm not there. That's been very helpful for us because we can capture patients when we're
absolutely.
not there. So we have overflow phone calls that goes to our AI agent. We have afternoon or sorry, weekend calls that go to our AI stuff. And that's still being trained. So we're very new to that too. We've had some patients
Sure.
come in and say, oh, I don't like that. I wasn't able to get what I wanted. Okay. So over time, that's going to improve. We all agree that that's a valuable thing for our practice and our practice management system here. So that's we're leveraging AI in that capacity. I
Really
do
quick, which one are you using? Which because there's even
there's
more
so
AI
many.
agents for phone calls, right? Which
So
one are you using?
I use a endodontic specific platform in my office called TDO, which is Total Digital Office. They came up with their own AI agent and the AI processes here too. So I'm staying within that platform. So it's TDO and it's endo specific. I
Gotcha.
don't know if they make that available for everybody. I'm not certain, but again, I want to be as congruent to the system that I'm using. I don't want to upset the apple cart too much here. So we're trying that. We've only really been using it maybe about a few months or so. So that's really new to us here. So we're still
Right.
working on that. The other capacity I use AI in is just my chart notes and things like that. And what I'm just going to Chat GPT. I've got the pro version, and all I'll do is I'll just dictate what I want the note to read. I've got it in my projects. I've got the memory of what I want it to frame the paragraph like. So before at the end of the day when I'm doing all my notes, I'd be there for like 45 minutes, an hour typing. I hate typing. I never took a typing class in high school. I'm like this on the keys. We all figure out how to type our own ways, but
Hmm.
I just don't like it. And then I started dictating my notes into just a microphone, which would do automatic, just would just kind of create a text version of it here. Now I'm dictating it into Chat GPT, and it's this polished note that is a story almost that I send back to my dentist. So that's how I'm using AI with our answering, and it saves me time when I'm making my chart notes. I can do like 10 chart notes in a matter of 10 or 15 minutes now, which is very, very time saving for me. But when it comes to practice, I haven't adopted any AI yet. Now I know they've got AI systems like Overjet and things like that that can read imaging and two-dimensional imaging. Sometimes that gets in my way, right? I'm not looking at all of that. I'm looking very closely at PDLs. I'm looking at laminiduras. I'm looking at bone density, bone quality, and there really isn't a fantastic AI interpretive software program that really looks at cone beam. Or maybe there is, and I just don't know about it. But nothing that I've come across that says, "Oh my gosh, I have to have that." And again, since I've been reading cone beams for so long, I think some of the AI may get in my way. And I'm only taking these limited field of view scans. I'm not taking these full mouth, or I'm not seeing the C spine. I don't want to see any of that anyway. So the technology I'm using in clinic is nothing to do with AI. It's cone beam scanning, but that's really not new. We're using a lot of advanced irrigation devices. Something like a product called GenoWave by a company called Sohn Endo. They're out of California, which leverages multisonic energy and fluid dynamics to really suck up the pulp. It creates these vortices and these vacuums that once you prepare the root canal system to a certain size, you create some sort of sealing platform on the tooth, and this device integrates with the sealing platform, and it creates this airtight seal that creates this environment that just really leverages these fluid dynamics and completely cleans the root canal system. It's fantastic. It's fantastic. Downside is a bit expensive. The other thing we have in our practice, we're using lasers. Lasers also are an advanced irrigation technique that will also enhance the cleansability of these systems. So for those of the people out there who don't do a lot of endo listening to this, there's something called patency. Patency is being able to take a small hand file slightly out of the root apex through the apical foramen. We used to struggle to get patency because patency and being able to get beyond that apical foramen by about a millimeter or two was one of the prognostic values for successful root canal treatment according to the literature. So we'd fight for this. We do file bending techniques, and we'd really try to find that exit point so that we could become patent, because we knew if we became patent, the odds of a successful treatment were going to be greater. Well, this advanced irrigation system, like the GenoWave or lasers, will actually remove the tissue from that last little millimeter so I don't have to struggle to look for it anymore. So I don't sit there and spend hours and hours and hours trying to bend files and become patent because I'm now leveraging that technology. The newest piece of technology that's come onto the market is something called ODNI. ODNI Clean is basically uses fine water jet that creates cavitation, and it's doing debris removal with basically water. And if there's one thing that I'm looking forward to in my specialty is the elimination of sodium hypochlorite. Sodium hypochlorite to clean the root canal systems has been around since the inception of root canal treatment itself. And it's grandfathered into the protocols that we use, but it's probably the most dangerous chemical that's used during endodontics. It's very caustic. It's just a nasty, nasty chemical. When it's in the confines of the root canal system, it's fine. But the problem is when it extends beyond the confines of the root canal system and gets into the periapical tissues, it's just going to be a disaster, and it's really nasty. So I'm looking forward to the day that somebody's going to tell me, well, Bill, you don't need to use sodium hypochlorite anymore. ODNI is making a push in that direction because now they're using water, and they're actually getting a really good cleaning result with just the water. Now, they're not advocating just using ODNI, but they're advocating using using the system to bulk debris removal and make sure the canals are clean, and then go with a final solution of sodium hypochlorite. There's another laser out there by AMD, the Picasso laser, and they've come out with a solution, a mixture of chlorhexidine and alcohol, and they're advocating that maybe we don't need to use sodium hypochlorite. The alcohol is going to be volatile, and it's going to kind of pull some of that chlorhexidine into those little fins, the little deltas, the tubules, to kind of clean that root canal system a little bit better without the need for sodium hypochlorite. So I'm hoping, Robert, that we're moving in that particular direction. Now, how soon that's going to be, I think it's going to be a generational shift because I think there's so many people ingrained in the thought process of having to use sodium hypochlorite that it's going to take a long time before we decide to put that up on the shelf and not use it anymore.
Have you tried either of those lasers?
I've got
Uh,
them all, and that's the fun thing about where I'm at in my practice in my career is I will spend the capital to try these things because it's what I love to do. So yeah, we've got three photona lasers, we got two GenaWaves, we got an AMD laser. They just sent it to me, so I haven't. I'm going to give that one a fair try. I haven't really tried enough cases to make a good comment on it, but I've tried the Odney system. I'm trying all this stuff here. When something comes out, I'm not the first one to jump in the pool. I'll let a couple other people kind of test the water for me. But I'm happy to try anything as long as it moves and raises the bar.
yeah, I saw an interesting article the other day. It was on Forbes. It was talking about the second mover advantage. Everyone always talks about, you've got the first mover and you're the first one and you've got this great shiny new toy. Nobody else has it. It's great. But you're also the one to find all the mistakes in theory as well, too, right? So having that second mover, like you say, let some other people try it, give proof of concept, and then all of a sudden, boom, you
Yeah.
found the sweet spot of what's going wrong. So,
I mean, it's kind of a nice position to be in because I get a lot of people offering or wanting me to try stuff, and unless that stuff is backed by some research or some validation of some kind, I'm not going to be the first one to try anything. I have done that before, Robert, where I've gone in and I've been the first person to try stuff, and it really hasn't worked well. And so I'm a lot more discerning now on what I choose to dabble with. And I don't use my patients as a benchtop. I just don't think that's fair. I know some people, when they get that new toy, they can't wait to try it. And the first thing they do is try it on a tooth. I always encourage people when they're getting something, use an extracted tooth. Make sure you understand that protocol, and not just you practice with it. Get with your team, the person who you're sitting next to helping you with the treatment. Practice with them because the technology is only as good as what you understand. If you don't help your team understand what that technology is used for or how they fit into the mix, then you're going to be all thumbs when it comes time for patient treatment.
great advice. Saves you from some potential lawsuits as well, too. Uh,
Possibly.
Possibly. Tell me one more question, we'll get into our rapid fire wisdom bites section. How does a laboratory like the Orm Group help you as an endodontist succeed?
Um, well, that's a good question because endodontists don't have lab fees, right?
I know that's why I'm like, well, how do we help you here? What's the yeah.
Well, our practice also places implants. So one thing that we do is we do implant guides for those patients that are going down the implant route. I placed implants for about 9 years. I didn't like it. I stopped placing them. It's not that I wasn't good at it, I just didn't care for it. I'd go to bed the night before an implant case and I'd think, oh, I got an implant tomorrow. And then I'm like, if I'm feeling this way, why am I doing it? Because I don't really need to do implants. But we do have an associate in our practice who's both endo and implant trained. So we do place implants in our group. So we do have a lab fee for our implant guides. Now,
Mhm.
if I want to try to get fancy and do some sort of apical surgery, you can do a surgical guide or something like that. There are access guides that people have used too to try to access. So from a laboratory standpoint, I think from endo, I think that's really the only relationship that a lab could have with endo is making some surgical guide for apicos, access guides, or if that practice also places implants.
Mhm. So tell me, at what point does the final solution come in? So let's say if we go way back to 20 minutes ago when we were talking about, you're looking, okay, I'm going to extract it, but I'm also going to restore it and place an implant. At what point do you bring that into the conversation with the patient to say, we can either do root canal therapy or we can extract it and put an implant in. Is that too much of an overload for them to process too much change, or at what point do you start to look at the final restorative aspect of things?
Well, we talk about that the consultation, So if I bring up extraction, and the patient then says, well, tell me more about that. What does that involve? And if I lose my tooth, what are my options when the tooth is gone? I'm like, well, when you lose your tooth, you have the option of leaving a blank space. You don't have to replace it. We encourage you to replace it, but it's not an absolute. So you can do nothing and leave a blank space. You can get a bridge, and a bridge links teeth together with artificial teeth in the middle, or you can get an implant, which is what we call a single tooth restoration. And then I go down the pros and cons of bridges versus implants and things like that. That happens during my consultation. Now, I don't bring it up during every consultation, but it's these more compromised teeth, what we call these teeth that we're doing dental heroics on. And gosh, I go into my practice, and there's not a day that I'm doing some sort of marginal elevation because the caries is down to the crestal bone. And we're getting a good long-term outcome on these cases, and we try to save them. But I'm going to be upfront with that patient and say, hey, listen, the other route here is this may not work, and we may want to consider an implant. So that discussion happens quite often, but it happens at the consultation because I need them to understand what that option looks like before they commit themselves to making the attempt to save a tooth that is a little bit more questionable than we both want.
That's a great answer. And just to touch on something you said earlier as well, to role play that out, make that conversation second nature with your patients as well, too. You mentioned that earlier. I wanted to just acknowledge that because
Yeah.
that's so important.
And I practiced in the mirror. I
Yeah,
practiced
that's
watching myself talk because it's body language. It's not just what you say, it's how it's being said, right? There's nuance in the conversation. And that nuance and how you position yourself and how you frame that is not just the words, it's how you look. So when you're practicing, don't just have a script. Practice a script in a mirror, just like you're an actor. The way we look at it is we're putting on a show for every single patient. That patient is the star, and we're all the supporting characters, and that's what we're trying to do. And every act is the same. We are what we do is so repetitive every single day. My team hates my jokes because they've heard them a million times, right? But it's all the same stuff. But the patient's hearing it for the first time, so it's funny to them. But you know how it goes.
absolutely that. And in the mirror is actually a really good tip because you could be delivering really tough news and your face could not reflect at all either the seriousness or the lightheartedness of that situation and people are looking at you.
100%.
They're looking at you to judge your body language and everything. So that's such a great tip. A lot of people really don't do that enough. I got to do it because I do this all the time and I got to practice it as well too. So let's roll right into our wisdom bites here, and then some rapid fire, whatever comes to the top of your head, and we'll go from there. So first one. What is one mistake that taught you something valuable?
Treating the wrong tooth. I've done that before. And when you treat the wrong tooth, it really shakes you, and it taught me to it's never happened again, right? So when we're putting rubber dams on, and it requires rubber dam. I used to work through this little hole. We used to get the rubber dam retainer or the rubber dam clamp. We call them retainers, semantics. Uh, and I put it on the wrong tooth and thought I was on the right one until I took my working length, and all of a sudden, all the cones are in a tooth next to the tooth with the lesion on it, and so it affected me. So now I apply my rubber dam differently so I don't make that mistake again.
How do you apply it differently? Can you get a little specific? Like how do you, I mean,
Well,
obviously.
the rubber dam retainer. So by the way, I say rubber dam retainer, not clamp. Patients don't like clamps. Nobody wants a clamp on their tooth, right? But they're okay with retainers. Orthodontics have made retainers household names. So we
Mhm.
ask for retainers. We've taken that language out of our clinic. So we have a lot of semantic language like that. Another thing like that is instead of needles, we ask for tips. Nobody wants a needle. So I ask for the blue tip, I ask for the yellow tip. So again, we change our terminology. But the rubber dam retainer has a bow, and then the jaws of the retainer have two little holes in it for that rubber dam forceps to engage it. Are you follow what I'm saying?
Mhm.
So off that rubber dam are called little wings, and those little wings are designed to hold that rubber dam on. And then when you're applying that rubber dam, you have your rubber dam your rubber dam forceps engaged in the holes of that rubber dam by the wings, and you're working through this little tiny hole, right? So it's easy to get it on the wrong tooth. So instead now of using those wings to support my rubber dam when I'm putting it on, I have the bulk of the rubber dam hanging off the bow. So that now when I'm engaged in that rubber dam forceps and applying it to the tooth, I don't even see the rubber dam. All I see is the rubber dam retainer, and I'm applying on the tooth, then stretching the rubber dam around the retainer after it's in place instead of working through a little hole. That changed the game for me.
It's a pro tip. I hope everyone implements that. Next one, next question. Something in dentistry we're getting wrong today.
Something in dentistry we're getting wrong today. Gosh, I'm going to take it back to what we first started about. Endo does not have a 95% success rate. That's what we're getting wrong. All right. It can, but in most cases, it doesn't.
Okay, good. Let's strike that. Everything we're talking about, one of the themes we've been talking about tonight is language, specific words as you're chatting with your patient about this scary procedure that's not scary. It won't be anymore after this conversation. It's not. It's 95% successful. It can be. Okay, little personal, little curveball for you here. Outside of work, what makes you better at what you do?
I love this question. I'm a musician. I went to college on a jazz drum scholarship. I'm a drummer and I play music. That's what makes me better at what I do. Some people meditate. That is my meditation. And when I come home from a difficult day, I can sit down, I can play music, and I can get lost in it for a long time. So that is what makes me better at what I do, is being able to have a creative outlet to continue doing what I like to do. And when I talk to dentists, there are a lot of creative dentists out there. Dentistry is very artistic, right? We're all there. There's a creative side to it. Lab work is artistic, right? We've got to be artists with this. And when we talk to somebody that does this kind of artistic work, they always have a hobby that reflects some sort of art. You may do woodworking, you may do cooking, you may write, you may do poetry, you may play music. So I find that a lot of people in these creative artistic fields also have hobbies that reflect that creativity too. Mine happens to be music, and that's what makes me better at what I do.
Doesn't hurt that with drumming as well too. Keeps you limber, keeps your muscles strong, your hands and your forearms, which you're using a lot in your day-to-day life. So
And
that's great.
coordination.
That's right. Absolutely. Coordination is key. Uh, Last one of the formal questions would be, this is the big one, so I'll give you a second to think about it. What is one piece of advice you hope everyone listening to this carries with them going forward?
It's not a race, right? So take your time, do quality work, treat your patients well, and be honest. That's it. That's the secret to success. That's it. Right. I don't set production goals. I look at I know my numbers, but I don't intentionally set production goals. I'm more interested in taking my time and doing the work right and making sure people are treated well. And that's, if anybody's listening, that's all you got to do. Treat people well, show empathy, and just do your best and be honest.
It's such a wholehearted take, but I gotta probe a little more. I gotta get you to tell me a little more because in today's world of DSOs of everything, it's KPIs, it's metrics, it's production goals. So what factors are you running an endo practice and a full education platform as well too? What metrics do you analyze and what metrics do you gauge your success on?
We are a full-scale business like everybody else's businesses. We've got a lot of KPIs that we look at. We look at the return on the value of our marketing. What's it cost for patient acquisition? We schedule for production. No, endo can be done in one visit, but sometimes it's split up to more than one visit. Our front desk is informed that you don't do two completes on the same day because that's not a productive day. We have a low volume practice. Some of my colleagues are doing maybe 9 to 10 root canals a day. A busy day for me is 5 or 4. And that really is all we need to do to really satisfy our financial needs and satisfy our clinical needs. So, to get into all the details of all the KPIs, I look at, there's a ton of them because again, I have a COO, I have a CFO, I have a marketing department, I have an advertising aide. I've got all the things that normal businesses have. And with the business conversation, Robert, is going to be very different from the endodontist bill conversation here.
Mhm.
We can maybe do another podcast if you want in the future on the business side of endodontics. But right now, we should probably keep it to the clinical.
Sure, fair enough. Okay, last question, which I'm going to throw at you, because I'm a big fan of The Bear on Hulu and Disney. Best restaurant in Chicago.
Best restaurant in Chicago, High Five Ramen. It's
High
uh,
Five Ramen.
it's a little ramen place on Green Street in the West Loop. Doesn't take reservations. Only got 16 seats. You got to show up early. You got to get in line, but it's fantastic.
Love ramen. Great, great. That's a hot take. That's a hot ramen take right there. I like that. Okay, so we're just about at time, but we got to let some people know how they can find out more about you because, again, we've literally scratched the surface here of everything new. So, a couple places they can find you is endochicagoland.com, home of the original Endo. And then we have newendoonline.com. So that's Nuendo online.com and on YouTube as well too. You've got your own YouTube channel and your own podcast. Tell me about your podcast. What is it all
Yeah,
about?
I'm really excited about this. A colleague of mine, Dr. Brett Gilbert, who also has an endodontic educational platform called Access Endo, we teamed up together and we have developed the podcast called For the Love of Endo. We're very early on in our growth as well. But what we're trying to do is approach endodontics and help educate the younger generation, and we call it Elevating Endodontics one conversation at a time. And that platform is gonna be endodontic technique. It's gonna be business. It's gonna be just anything that involves endodontic practice here. And we're really looking forward to getting an audience there too. So it's very exciting. Maybe Robert, maybe we'll have you on our podcast and we can talk about the lab. How about that?
Perfect. I'm ready when you are. I'll brush up
Great.
on all my endo lab related topics. And then and then lastly, online on social media, you're on Instagram at newendo.online is your handle. Dr. Nudera, thank you so much for your time. I really appreciate it. Any parting words before we sign off for the session?
Well, I want to just say one thing to you. Thank you for doing this. I know there's a lot of people that you can ask to come on and chat with, and I want to thank the people watching this because there's a lot of things you can do with your time, and I'm just grateful that you spent the time with me today, and I hope that the people watching and you have gotten something out of this. I love talking about it. If you can't tell, it's just my passion. It's what I love to do. And I'm always happy to chat about this stuff. So I'm grateful for the opportunity.
Well, we're grateful to have you here. Endo needs to be talked about more because it is such a common procedure. So, again, thank you for your time, and thank you everyone for listening and watching. Robert Hawkins, I'm your guide to dental excellence, and we'll see you next week on the Aura Meridian. Thanks, Dr. Nudera.
Thank you.
Bye bye.